Hello everyone, I'm Dr. Zohre Sharifi-Rad. It's a NAC OSCE presentation in patients with shortness of breath. By definition, shortness of breath is often described as intense tightening in the chest, air hunger, difficulty breathing, breathlessness, or a feeling of suffocation. Very strenuous exercise, extreme temperature, obesity, and higher altitude all can cause shortness of breath in a healthy person. Differential diagnoses include acute coronary syndrome that frequently present with retroesternal chest discomfort and difficulty catching the breath. And risk factors include old age, smoking, hypertension, and hyperlipidemia. COVID 19. People that have been infected by COVID 19 may have symptoms such as fever, dry cough, loss of smell and taste, and in moderate to severe cases, shortness of breath. Congestive heart failure that present with shortness of breath with exertion, orthopnea, and paroxysmal nocturnal dyspnea. Risk factors for acute decompensation include high dietary salt intake, medication noncompliance, and cardiac ischemia. Chronic obstructive pulmonary disease. The patients have shortness of breath and chronic productive cough. COPD is a risk factor for pneumonia, thus, this condition should be ruled out. Asthma. It's the most common reason for presenting to the ER with shortness of breath. Other symptoms include wheezing, tightness in the chest, and non-productive cough. Inhaled corticosteroid are preferred treatment, and also symptoms are treated with short-acting bronchodilators. Pneumothorax present typically with pleuritic chest pain of acute onset and shortness of breath, non-improved with oxygen. Physical finding may include absent breath sound on one side of the chest, jugular venous distension, and tracheal deviation. Pneumonia. The symptoms include fever, productive cough, shortness of breath, and pleuritic chest pain. Inspiratory crackle may be heard on exam. Chest X-ray can be useful for differentiate pneumonia from CHF. Pulmonary embolism classically present with acute onset of shortness of breath and pleuritic chest pain, cough, hemoptysis, and fever. Risk factors include deep venous thrombosis, recent surgery, cancer, and previous thromboembolism. Treatment depending on severity of symptoms typically start with anticoagulant, and signs of low blood pressure may warrant the use of thrombolytic drugs. Anemia develop gradually, and menstruation, particularly if excessive, can contribute to anemia, to consequential dyspnea in women. Other symptoms include headache, numb sensation in the head, and blurry vision, and also loss of concentration and fatigue. Other important common cause of shortness of breath include cardiac tamponade, anaphylaxis, and also panic attack. In the history taking, we should ask the patient about onset, course, and duration of the chief complaint, like how did it start. In the setting, we should ask the patient, what were you doing when it started? Were you dusting or exercising? In the quality, we should ask the patient, how does it feel like? Is it like air hunger, suffocation, or heavy breathing? Rapid shallow breathing, chest tightness, increased breathing effort. In the severity, we should ask the patient, how frequent do you have it? How many times a week? When you get it, are you able to speak? Any visit to ER in the past or an intubation? For timing, we should ask, is it worse in the particular time of the day? What makes it better or what makes it worse, like exercise, lying down? And ask about the number of the pillows that patient use at night. And have you ever had wake up at night for gasping for air? Associated symptoms, ask about any wheeze, stridor, hoarseness, any exercise intolerance, any ankle swelling, pain in the leg, and also heart racing, or the other signs of upper respiratory tract infection like runny nose or cough. Ask about recent travel, contact with the sick person with the same symptoms. And in the past medical history, ask the patient, do you have any past history of any disease that I should be aware of? Have you ever had used any medication? Do you have any allergy? Or have you ever had any surgery before? Family history. Any disease runs in your family that I should be aware of? And ask about social history. Smoking is so important. The using drugs like marijuana, emotional changes, and ask about the occupation of the patient. What do you do for a living? In the physical examination, do vital signs. If the patient is unstable, do right away ABC of the emergency. In general inspection, if the patient is three-foot position, the patient have nasal flaring, pursed lip, use of accessory muscle, or if the patient looks pale, cyanotic, or the patient have cough, wheeze, or stridor. Check the mouth and hand, and also do complete physical examination of the lungs, heart, and also legs. In managing patient, if the patient is in severe attack, having additional help from nurse, medics, or other emergency department staff is tremendously useful. While you are assessing your patient ABC, you should request the following to occur simultaneously. Full set of vital signs, including blood pressure, heart rate, respiratory rate, or O2 saturation and temperature. Oxygen application via nasal cannula, non-rebreathe mask, or back valve mask if patient require associated ventilation. Cardiac and pulse oximetry monitoring. IV access, including blood draw for ABG or VBG, and other routine testing. In some cases, obtaining an EKG may be useful as well. After stabilizing the patient, start secondary survey and complete history and physical examination, and treat the patient based on the lab result and your finding, and do referral if needed. Some key elements of the history. Did the shortness of breath begin suddenly? If so, consider pulmonary embolism or spontaneous pneumothorax. A gradual onset of symptoms is more suggestive of COPD, pneumonia, or CHF. Is the shortness of breath chronic or recurrent? Many chronic disease processes can acutely worsen from time to time. Your patient may even be able to tell you that his or her symptoms are similar to the last episode of asthma, COPD, CHF, or pneumonia. Is the shortness of breath positional or exertional? Orthopnea is typically thought of as symptoms of CHF, but can also occur in COPD and also in neuromuscular disorder. Exertional dyspnea can also have multiple causes, including primary pulmonary disease, cardiac ischemia, or anemia. Were there any precipitating event, shortness of breath occurring after environmental or non-allergen exposure can be a clue in diagnosis as an allergic reaction. Similarly, recent hospitalization or prolonged travel may raise your suspicion for pulmonary emboli. Does your patient have any pertinent past medical history? As stated above, a history of asthma, COPD, or CHF, for example, can suggest a cause for your patient's symptoms. Suspicion for developing angioedema may be higher if your patient has a history of hypertension treated with ACE inhibitors. And some key elements for physical examination. Leaning to recognize patients that support your history can make your evaluation more efficient. Visible swelling in the upper airway can point to allergic reaction or angioedema. Voice changes, stridor, and drooling are ominous signs concerning for impending airway obstruction and can be related to infection, allergic reaction, or foreign body. Focally absent or diminished breath sound on auscultation can suggest an infectious consolidation, effusion, or pneumothorax. Wheezing can be attributed to bronchospasmodic process such as asthma, COPD, or anaphylaxis. Rales can be found in pneumonia, pulmonary emboli, and pleural effusion. Rales in the setting of jugular venous distension, and peripheral edema can be suspicion for CHF. Unilateral leg swelling and tenderness raise suspicion for DVT or pulmonary emboli. Signs of chest trauma, including crepitus, bruise, and tenderness, can be suggestive of pneumothorax, hemothorax, or pulmonary contusion. Tripoding or use of accessory muscle may be less helpful in determining the etiology, but can be sign impending respiratory failure and need for immediate intervention. Thank you very much for your attention.